Hey everyone, so now we're going to discuss a little bit more about arterial blood gases. This is the second recording. The first recording was about respiratory acidosis, if you want to go back and check that out. Anytime that we are dissecting an ABG and labeling it, we need to look at a few different characteristics that and numbers, results, whatever you want to call them, but we need to give them a good look at, and that is the pH. Is the pH within normal range? Is it that perfect 7.40, or is it within normal range of 7.35 to 7.45? If it's below 7.35, we know that means it's acidotic. If it's above 7.45, that means it's alkalotic. Anytime that we have an acidotic blood gas below 7.35, we know that there's going to be a higher PCO2. If we have an alkalotic blood gas above 7.45, then we know that there's going to be a lower PCO2, because what typically happens there is the patient is hyperventilating and blowing off that PCO2. So a good example that we're going to look at next is of an 18-year-old patient that comes into the emergency room, bay number 4, and they're tachypnic, using their accessory muscle use. They're a bit diaphoretic because they've had an exacerbation of their asthma. So the pH that we see on our ABG is 7.55. So that means that it is alkalotic, and it also means that it's non-compensated. It's non-compensated because it is out of that 7.35 to 7.45 range. For our young fella with the asthma, his PCO2 is 25. So we know that he is hyperventilating. He's taking more breaths than normal, so above 20. He's probably, in the 30s, because he's taking those small, quick breaths because he's so constricted and having some inflammation from the constriction, and he's just uncomfortable. So his the PO2 is only 59. And that's because he, again, is so constricted, and the smooth muscle in the airway is constricted, and that oxygen just can't get through to the alveoli and across the alveolar capillary membrane and onto the red blood cell to be delivered to the tissue. So he's not only is he in respiratory alkalosis, he's also uncompensated, and he's also hypoxemic because his oxygen level is below normal. So his bicarb is 22, which is within normal range. We know that it takes a bit for the kidneys to kick in and for there to be more bicarb produced to help with the compensation of the pH. So what can we do for this patient? Well, we realize that he has non-compensated respiratory alkalosis with hypoxemia. So of course we're going to treat the hypoxemia with supplemental oxygen. We're probably going to put him on a nasal cannula or a venti mask. And then we're going to try to get his airway open with bronchodilators and relieve that bronchospasm, get that smooth muscle to relax. Now we can try albuterol. If one treatment doesn't work, or maybe two, then we may want to put him on a continuous albuterol treatment and just let it run. We may have to add an anticholinergic like Atrovent. We may have to add some Solumedrol by IV. A little side note there, that when you give a patient Solumedrol by IV, a lot of times you'll hear them complain that they can feel the medication actually going through their veins. It does have a little bit of a burn to it, and that's a normal feeling, that side effect. So don't be alarmed if they say that. But the benefits far outweigh the little burning sensation as the corticosteroid begins to decrease the inflammation and help help the smooth muscle to relax and bronchodilate, and the patient increased airway resistance that they were experiencing during the asthma attack will be relieved, and they'll hopefully be able to go home. Now, if this doesn't work out, then we're going to have to look at maybe intubation. Asthma is definitely a potentially deadly condition, and the patient may have to be intubated, and then we would use small tidal volumes. If you remember, we're going to base our tidal volumes for our status asthmaticus patient on about 4 milliliters per kilogram of ideal body weight when we calculate that tidal volume and set our ventilator. We don't want to cause barrel trauma, and where they're already clamped down with bronchospasm, that would be definitely easier to do if you used a larger tidal volume. So let's stick to that tidal volume of around 4 milliliters per kilogram of ideal body weight for asthmatics. So hopefully we will get this respiratory alkalosis compensated, get the pH back to that in range between 7.35 and 7.45, and we'll get the PCO2 back to the 35 to 45 normal, get the PO2 back up between 80 and 100, and be able to send this patient home and back to their regular daily life, and maybe with a peak flow meter and a good care plan to keep them out of the emergency room and living comfortably at home. So, all right, well, thanks for listening. Be sure to email with any questions, and join us on the study group, RRT and Neonatal Pediatric Specialist Review, and we'd be glad to have you if you're not already there. All are welcome. Thank you.